Welcome to the deep dive.
Yeah.
Sometimes you want to really get to grips with a health topic, understand it properly, but maybe without wading through dense medical texts.
Exactly. And that's our plan today. We're focusing on colorectal cancer.
Right. It's something that understanding really can make a difference for you and, people you care about.
Think of this as your high-yield guide. We've taken some comprehensive revision notes and we're boiling them down to the absolute must-know info.
Clear, memorable, something you can actually use.
That's the goal.
So our mission today extracts the crucial bits about colorectal cancer, what it is, what causes it, the risks,
How it develops, what else it might look like, who gets it, the symptoms.
how it's diagnosed, treated, the outlook, potential problems, the whole picture, really.
Yeah, it sounds like a lot, but we'll structure it, break it down, maybe add some memory aids along the way.
Make it stick. Okay, ready to dive in?
Absolutely. Let's kick things off at the definition. What is colorectal cancer? So, simply put, it's a malignant tumor, a cancerous growth that starts in the colon or the rectum.
Right, the large bowel.
Exactly.
Yeah.
And a really key point is how it usually starts. In most cases, maybe 95%, it doesn't just appear fully formed.
It develops over time.
Precisely. It often begins as a benign polyp. Think of these as small, non-cancerous growths on the lining inside the colon or rectum.
Okay, like little bumps.
Yeah. And over several years, these polyps can change, the cells can mutate, and eventually they can become cancerous, invading the bowel wall.
So that progression from polyp to cancer is pretty typical then.
Very typical for the majority of cases. Now, you mentioned types earlier.
I did. Sporadic, HNPCC, and FAP.
Right. So sporadic is the most common, like we said, around 95%. We can't point to a specific inherited gene fault in these cases. It seems to happen more by chance, influenced by age and environment.
Okay, that's the vast majority. What about HNPCC?
HNPCC stands for Hereditary Non-Polyposis Colorectal Carcinoma. It's better known as Lynch syndrome. That accounts for about 5%.
Still significant.
Definitely. And the key here is hereditary. It's an inherited condition that significantly increases risk. We'll touch on the genes involved soon.
Got it. And FAP?
FAP, or familial adenomatous polyposis, is much rarer, less than 1%. Its hallmark is the development of hundreds, sometimes thousands, of polyps throughout the colon, usually starting quite young.
Wow, 100.
Yeah, it dramatically increases cancer risk if the colon isn't removed. So, a quick recap. Sporadic, most common, seems random. HNPC Lynch, inherited risk, fewer polyps. FAP, inherited, lots of polyps.
That helps clarify it. So focusing on the sporadic type mainly, what actually causes it? What's the etiology?
Well, the exact trigger isn't known for sure. It's generally seen as a complex interplay between genetic factors and environmental influences.
A mix of nature and nurture, kind of?
Pretty much. On the genetic side, even in sporadic cases, certain mutations changes in the DNA of the colon cells accumulate over time. Genes like APC, KRAS, TP53 are often involved.
These are genes that normally control cell growth.
Exactly. They're like the instruction manual. If you get typos or errors, specifically mutations, in these genes, cell growth can go unchecked, leading to cancer.
Makes sense. And the environmental side.
There are several factors linked to increased risk. Things like diet, specifically diets high in fat and low in fiber. Also, a sedentary lifestyle, not enough physical activity.
Okay.
Obesity is another factor, as is smoking and excessive alcohol consumption. These lifestyle elements can contribute to the conditions that allow those cellular changes to happen.
Right. Now, going back to the hereditary side, HNPCC and FAP, can we elaborate on the specific genetics there?
Sure. Lynch syndrome, HNPCC, is usually caused by inheriting a mutation in one of several specific genes responsible for DNA mismatch repair. Think of them as the spell checkers for DNA.
So if the spell checker's broken,
Errors aren't corrected, mutations build up faster. It's typically autosomal dominant, meaning inheriting just one faulty copy of the gene increases risk significantly.
which genes are most common?
The main ones are MSH2, that's about 60% of cases, and MLH1, around 30%. And Lynch syndrome tends to cause cancers more often in the proximal or right side of the colon.
And wasn't there a link to other cancers too?
Yes, absolutely crucial point. Lynch syndrome significantly raises the risk of other cancers, especially endometrial cancer in women, but also ovarian, stomach, small bowel, and others. So Lynch links to multiple cancers.
That's really important for families affected. And FAP.
FAP is almost always caused by inheriting a mutation in the APC gene. This gene acts like a brake on cell growth.
So if the APC gene is faulty, the brakes are off, leading to that massive polyp growth we talked about, usually starting in adolescence. And without surgery to remove the colon, Cancer is almost inevitable, often by age 40. Think FAP, faulty APC, equals prolific polyps.
Okay, that paints a clear picture of the inherited forms. So pulling it all together, what are the general risk factors we should all be aware of?
Well, age is definitely a major one. Risk increases significantly after 50. That's why screening often starts around then.
Right. Personal history is key too. If you've had colorectal polyps or cancer before, your risk is higher. Same goes for family history. Having close relatives, especially if they were diagnosed young, increases risk.
Makes sense. What about other conditions?
Inflammatory bowel diseases like Crohn's disease and ulcerative colitis are important risk factors due to the chronic inflammation they cause in the bowel lining.
That constant irritation.
Seems to promote cell changes over time. Then, of course, the genetic syndromes we just covered, Lynch and FAP, confer very high risk.
And the lifestyle factors again.
Yep, they come up consistently. Diet high in red and processed meats, obesity, smoking, heavy alcohol use, lack of physical activity. These are all modifiable risks, things people can potentially change.
So, sort of the usual suspects for many health issues, really.
They are indeed. Think age 50 plus family history, IBD, inherited syndromes, plus those lifestyle bad habits. Those are the big ones.
Our notes also mentioned a few other, maybe less common factors. Hormonal things, past treatments.
Yes, some additional points. A family history specifically of colorectal neoplasia, which means cancer or adenomas, precancerous polyps, in a relative under 60 is a bit more specific risk factor.
Okay.
Having had any colorectal neoplasm yourself in the past. For women, some studies suggest nulliparity, no pregnancies, late first pregnancy, or early menopause might slightly increase risk, possibly hormonal links.
Interesting.
Diet, again, low fiber, folate, calcium, high meat fat. Also, having diabetes, having had previous pelvic radiation therapy, certain occupational exposures like asbestos, and even a history of certain other cancers like small bowel, endometrial, breast, or ovarian.
Quite a wide range of potential influences, isn't it?
It really is. It highlights that it's often multifactorial.
So, assuming some of these factors are at play, how does the cancer actually develop? What's the step-by-step process, the pathophysiology?
It generally follows that pathway we mentioned earlier. It starts with those benign polyps forming in the lining of the colon or rectum. Then, over time, usually years, a series of genetic mutations accumulate within the cells of the polyp. These mutations disrupt normal cell control mechanisms.
Like taking off the brakes and pushing the accelerator.
That's a great analogy. You get uncontrolled cell growth, and the polyp transforms into a malignant tumor. This tumor can then grow deeper, invading through the layers of the bowel wall.
And then it can spread.
Yes. If it's not caught and treated, cancer cells can break away and travel through the lymphatic system to nearby lymph nodes or enter the bloodstream to travel to distant organs.
Where does it typically spread to?
The most common site by far is the liver, because the blood supply from the colon drains directly to it. The lungs are usually the next most common site. That spread is called metastasis. So the pathway: polyp mutations, uncontrolled growth, invasion, metastasis.
That progression makes sense. Now, if someone has symptoms that might be colorectal cancer, what else could be causing them? What are the main differential diagnoses?
That's crucial, as symptoms often overlap. Inflammatory bowel disease, Crohn's, or ulcerative colitis can cause similar pain, bleeding, and bowel changes.
Right.
Irritable bowel syndrome, IBS, can cause changes in bowel habit and abdominal discomfort, though usually not bleeding. Diverticulitis, inflammation of little pouches in the colon, causes pain, sometimes fever, and bowel changes.
Very common.
And hemorrhoids are a very common cause of rectal bleeding and discomfort. Benign polyps themselves might cause bleeding. Less commonly, things like anal cancer, GI cysts, gastrointestinal stromal tumors, or ischemic colitis-reduced blood flow need to be considered.
So quite a list to rule out.
Definitely. Think. Could it be inflammation like IBD or diverticulitis, functional like IBS, something very common like hemorrhoids or benign polyps, or something rarer? Always needs proper investigation.
Which brings us to the bigger picture. Who actually gets colorectal cancer in the UK? What's the epidemiology?
Well, in the UK, it's a major cancer. It's the fourth most common overall.
Wow.
Yeah, it accounts for about 11% of all new cancer cases. And sadly, it's the second leading cause of cancer death.
That's quite stark.
It really highlights the need for awareness and early detection. As we've said, age is key. Risk climbs sharply after 50. Most cases are in the over 75s, with the peak incidence in the 85-89 age group.
And where in the bowel is it most common?
The rectum is actually the most common single site for it to start.
Okay. And you mentioned late diagnosis.
Yes, that's a significant challenge.
Yeah.
Over half, more than 50%, are diagnosed at a later stage, stages 3 or 4, when treatment is harder and outcomes are poorer.
That's worrying. Any differences based on ethnicity?
In the UK context, it tends to be more common in white individuals compared to other ethnic groups.
And screening programs.
Yes. Thankfully, we have national bowel cancer screening programs like the FIT test sent through the post, which aim to catch cancer or precancerous polyps much earlier, precisely to combat that late diagnosis issue.
Those sound incredibly important. So moving on to how it actually shows up, what are the typical clinical features, the signs and symptoms?
It can be quite varied depending on where the tumor is and how advanced it is, but there are common themes. A persistent change in bowel habit is a big one. That could be new diarrhea or constipation or just a change in frequency or consistency that lasts for, say, 3 weeks or more.
Okay, a change that sticks around.
Exactly.
Yeah.
Rectal bleeding, seeing blood in the stool or on the toilet paper is another key symptom. Never ignore that.
Definitely not.
Abdominal pain, discomfort, or cramps, especially if they're new and persistent. Unexplained weight loss, losing weight without trying. Persistent fatigue or tiredness, often linked to anemia.
Anemia.
Yes, iron deficiency anemia. The cancer can bleed slowly and invisibly, leading to low iron levels. And sometimes a feeling that the bowel isn't emptying completely, even after going to the toilet, that's called tenesmus.
So key things, bowel changes, bleeding, tummy pain, weight loss, tiredness, that incomplete emptying feeling.
Those are the main ones to watch for.
You mentioned location matters. Is there a difference between right-sided and left-sided colon cancers?
Yes, there often is a difference in presentation. Right-sided colon cancers, because the colon is wider there and the stool is more liquid, tend to cause symptoms later.
Ah,
They often present more vaguely, maybe with unexplained weight loss, iron deficiency anemia from that slow, unnoticed bleeding, general fatigue, or sometimes a lump felt in the right lower abdomen, often diagnosed at a more advanced stage because the symptoms aren't as alarming early on.
right, more subtle.
Whereas left-sided colon cancers, being closer to the rectum, where the stool is more solid, tend to cause more obvious bowel symptoms earlier.
Like blockages.
Exactly. Things like colicky pain, more obvious rectal bleeding, constipation, or passing narrower stools. Tenesmus is more common too, sometimes a lump on the left side. Because the symptoms are often more noticeable, they tend to get diagnosed a bit earlier than right-sided ones.
That's a useful distinction. Right side, more vague, often anemia, later stage. Left side, more bowel obstruction bleeding signs, maybe earlier stage.
That's a good summary.
So what are the absolute critical red flag symptoms that must prompt a doctor's visit?
The big ones are rectal bleeding. Any persistent, unexplained change in bowel habit lasting over, say, 3 weeks, especially if you're over 40 or 50. And unexplained iron deficiency anemia.
Got it.
If someone comes in with those, a thorough history, abdominal exam, and importantly, a digital rectal examination are essential first steps.
And what about signs of more advanced disease?
We look for things like jaundice yellow skinese or an enlarged lumpy liver, which could suggest liver metastases. A site's fluid buildup in the abdomen can indicate spread to the lining of the abdomen.
How common is spread to the liver?
Unfortunately, quite common. Maybe 20–25% have liver mets at the time of initial diagnosis, and up to 50% might develop them within 3 years after surgery for the primary tumor.
Why, that's high.
It is. Rarer signs might include things like pneumaturia, air and urine suggesting a fistula to the bladder, certain abscesses near the rectum, or sometimes even unexpected blood clots like DVTs.
Okay, that covers how it might present. So if colorectal cancer is suspected, how is the diagnosis confirmed? What investigations are done?
Well, screening tests like the FIT test or screening sigmoidoscopy might pick things up early in people without symptoms.
But for diagnosis?
The gold standard is a colonoscopy with biopsy. This involves using a flexible camera to look at the entire lining of the colon and rectum.
See everything.
Exactly. And if any suspicious areas or polyps are seen, small tissue samples biopsies are taken and sent to the lab to be examined under a microscope. That confirms if cancer cells are present.
So colonoscopy plus biopsy is key for confirmation. What about figuring out how far it's spread?
That's staging, and it's crucial for planning treatment. Imaging is vital here. Usually, a contrast-enhanced CT scan of the chest, abdomen, and pelvis is done for colon cancer.
Okay.
For rectal cancer, an MRI scan of the pelvis is often preferred because it gives really detailed pictures of the local tissues and helps surgeons plan.
MRI for rectal, CT for colon staging. Got it.
Blood tests are also done, including checking for anemia and liver function. The CEA tumor marker blood test isn't reliable for diagnosis, but it can be useful baseline to monitor treatment response or detect recurrence later.
Right.
Sometimes further staging might involve a liver ultrasound or biopsy if CT is unclear, or occasionally a PT-CT scan if looking for widespread disease. All this info feeds into the TNM staging system.
TNM.
T for tumor size and depth of invasion, N for spread to nearby lymph nodes, and M for metastasis to distant sites.
Okay, so that gives this stage, like stage 1, 2, 3, 4.
Precisely. Stage 0 is just the lining. Stage 1 invades the wall. Stage 2 goes through the wall. Stage 3 involves lymph nodes. And stage 4 means distant spread, like liver or lungs. There's also grading, how abnormal the cells look under the microscope, grade 1 to 3.
So see it, colonoscopy, sample it, biopsy, scan it, CT, MRI, stage it, TNM.
That's a perfect summary of the investigation process, and all this guides the management plan.
Right. So let's talk about management. How is colorectal cancer treated?
It's very much tailored to the individual, depends heavily on the stage, the location, colon versus rectum, and the person's overall health and fitness.
Makes sense. What are the main options?
The cornerstones are surgery, chemotherapy, and radiotherapy. Targeted therapy and immunotherapy are also becoming increasingly important, especially for advanced disease.
Let's start with surgery.
Surgery is the main curative treatment for localized disease. The aim is to remove the section of the bowel containing the tumor, along with nearby lymph nodes.
What kind of surgery?
Depends on location. Could be a right hemicolectomy, left hemicolectomy, sigmoid colectomy, or for rectal cancer, an anterior resection, or sometimes an abdominoperineal AP resection, which involves removing the anus and creating a permanent colostomy.
Okay.
Increasingly, these are done laparoscopically, keyhole surgery, which often means faster recovery. For rectal cancer, a specific technique called total mesorectal excision, TME, is crucial for removing all surrounding tissue and significantly reduces the chance of the cancer coming back locally.
TME for rectal cancer, important. What about removing metastases?
Yes, if cancer has spread, say, only to the liver or lungs, and those metastases are deemed resectable, surgery to remove them might be considered, often alongside chemotherapy.
Okay. When does radiotherapy come in?
Radiotherapy is used much more often for rectal cancer than colon cancer. It might be given before surgery, neoadjuvant radiotherapy, often with chemo, to shrink the tumor and make it easier to remove completely, or sometimes after surgery, adjuvant radiotherapy.
Primarily for rectal cancer, then?
Primarily. For liver metastases that can't be removed surgically, sometimes specialized radiation techniques like radiofrequency ablation or SIRT might be options.
And chemotherapy?
Chemotherapy uses drugs to kill cancer cells.
Yeah.
It's used in several scenarios. Adjuvant chemo, given after surgery for stage 3 colon cancer and sometimes high-risk stage 2, aims to kill any microscopic cells left behind and reduce recurrence risk.
Okay, after surgery.
It's also the main treatment for metastatic stage 4 disease, often used in combination regimens like FOLFOX or FOLFIRI, sometimes with targeted therapies.
Targeted therapies.
These drugs target specific molecules involved in cancer growth. For example, drugs like cetuximab or panitumumab target EGFR, but they only work if the cancer has a wild-type, non-mutated RAS gene. So genetic testing of the tumor is essential first.
Ah, so it's becoming more personalized.
Very much so. Other targeted drugs like bevacizumab target blood vessel growth, and newer drugs like regorafenib might be used if other treatments stop working. Immunotherapy is also an option for a small subset of advanced cancers with specific features like high microsatellite instability, MSIH.
So lots of options, often used in combination or sequence.
Exactly. For metastatic disease, especially liver mets, the ideal is often surgery plus chemo if possible. If it spreads to the lungs, the second most common site, a multidisciplinary team decides the best approach. Follow-up after curative surgery is vital, usually involving regular CT scans and CEA blood tests.
You mentioned nice quality standards earlier.
Yes, NICE guidelines in the UK emphasize key things, like offering Lynch syndrome testing to all newly diagnosed patients, discussing all options for early rectal cancer, doing RAS-BRAF testing in metastatic disease to guide targeted therapy, and having a clear follow-up plan after surgery.
And any future trends.
The big push is towards more personalized medicine using biomarkers from the tumor's genes to predict which chemo or targeted drugs will work best for that specific patient, maximizing effectiveness and minimizing side effects.
That sounds promising. So shifting gears slightly, what's the general outlook? What's the prognosis?
The single biggest factor influencing prognosis is the stage at diagnosis. Early detection makes a massive difference.
We keep coming back to that.
Absolutely. In the UK, looking at 5-year survival rates for localized disease, stage 12, it's around 90%. If it spread regionally to lymph nodes, stage 3, it's about 70%. But if it spread distantly, stage 4, survival is much lower, maybe 15%.
Huge difference.
It really is. Timely diagnosis, getting the right treatment promptly, and sticking with the plan are all crucial. And post-treatment surveillance is key for catching recurrence early if it happens. Remember, early stage will best outlook.
Given how important early detection is, what about prevention? Can people reduce their risk?
Yes, definitely. Many of the risk factors we discussed are modifiable. Maintaining a healthy weight, being physically active, not smoking, these are major.
Diet too.
Yes, a diet high in fruits, vegetables, and fiber, and low in red and processed meats and saturated fat is recommended. Ensuring adequate intake of things like folate, selenium, and calcium might also play a role, though evidence is still evolving.
Any medications?
Some research suggests long-term use of NSAIDs or even low-dose aspirin might reduce risk, particularly of advanced polyps or cancer. But this isn't a general recommendation due to potential side effects like bleeding. It's something to discuss carefully with a doctor based on individual risk. Hormone replacement therapy in women might have some effect too, but again, complex balance of risks and benefits.
So focus on lifestyle is the main actionable advice.
For most people, yes. Healthy lifestyle is key.
What's the overall survival picture in the UK now?
Overall, about 50–60% of people diagnosed with colorectal cancer will survive for 5 years or more. For those able to have potentially curative surgery, around 70% survive 7 years. And importantly, survival rates have been steadily improving over the last few decades due to better screening, diagnosis, and treatments.
That's definitely positive news. Finally, what are the potential complications we need to be aware of?
Complications can arise from the cancer itself or the treatment. From the cancer, you can get local recurrence, where it comes back near the original site, or distant metastasis, most often liver and lungs.
Okay.
The primary tumor can also cause problems like bowel obstruction, a blockage, or perforation, a hole in the bowel wall, which is an emergency, bleeding, leading to anemia. Malnutrition can also occur.
And from treatment?
Surgery has risks like infection, bleeding, leaks where the bowel is joined, and potential long-term changes in bowel function or the need for a stoma. Chemo and radiotherapy have their own side effects like fatigue, nausea, nerve damage, or bowel irritation.
So managing these is part of the overall care.
Absolutely. Early detection and good management help reduce the risk of many cancer-related complications, and managing treatment side effects is a key part of patient support.
Okay, this has been incredibly thorough. Let's try and summarize the key takeaways.
I think the main message is that colorectal cancer is complex, yes, but understanding the basics, the risks, the symptoms, the importance of screening is really powerful.
Absolutely. Being aware of those potential symptoms like changes in bowel habit or rectal bleeding and knowing your personal risk factors, especially family history and age, is crucial for taking action early.
And early action, early detection is fundamentally what leads to better outcomes. We can't stress that enough.
So maybe a final thought for everyone listening. Just take a moment to consider how your own lifestyle choices and your awareness of your body can impact your long-term health. It's worth reflecting on.
Well said. And for anyone wanting to delve deeper or find more resources, especially if you're preparing for exams like the MSRA.
Check out passthemsra.com and also freemsra.com. Lots of valuable information there.
Definitely good resources. Staying informed is key.
Thanks so much for sharing all that insight today. And thank you all for joining us on this deep dive. We'll catch you next time.